Hi, good afternoon, everyone. Our colleague Petya cannot stay here, so I will present. We'll go through the flash talks. We'll resume the presentations with the flash talks this afternoon. We have 3 flash talks before the closure of a plenary session. And just to remind that these are talks that should last around 8 minutes, and then for each we will have 2 minutes of discussion. Okay? So our first speaker is Mariarca Ascione from the Virtual Reality Group at the UBneuro, so the University of Barcelona group, with a presentation, a single session of an attentional bias modification task based on virtual reality and eye tracking to reduce attentional bias and body dissatisfaction in anorexia nervosa.
Aquí también no sé si está encendido. Vale, gracias. Good morning, and today I will present an innovative attentional bias modification training based on virtual reality and eye tracking for anorexia nervosa patients. Anorexia nervosa patients show body-related attentional bias by paying more attention to weight-related body parts than non-weight-related body parts. This specific body-related attentional bias has been associated with higher levels of body dissatisfaction, which is one of the most important risk factors for the development and maintenance of eating disorder. And also, it may be responsible for decreasing the effectiveness of body exposure treatment used to reduce anorexia nervosa symptomatology. Attentional bias, body-related attentional bias play an important role in anorexia nervosa. So it's really necessary to reduce this specific cognitive bias to improve its symptomatology and treatments. Attentional bias modification training has been considered a promising and effective intervention tool to reduce attentional bias in many psychological disorders, but has not yet been explored in eating disorder. Currently, our group is the first one to have developed an ABMT, an attentional bias modification training based on eye tracking and virtual reality technologies. The combination of these technologies allowed to create more ecologically and highly flexible setting by simulating real-life situation, while the attentional bias, the eye movement are recorded for the entire duration of a task. This ABMT has already been found effective in reduce attentional bias in healthy women. So this current pilot study want to evaluate the efficacy of a single session of this innovative ABMT in anorexia nervosa patients to reduce attentional bias measures and also body dissatisfaction levels. 23 adolescent patients participated in the study, patients with anorexia nervosa. The procedure consists of different steps. First, we create a virtual avatar. To do that, we take a frontal photo of the picture of the participant, and we manually overlap the different dimensions of the virtual avatar to fit into the silhouette of the participant. Then all participants were immersed in the virtual environment by using a head-mounted display, 2 head controllers, and 2 foot trackers to achieve the full body motion tracking. The virtual avatar was a room with a large mirror on the wall in front of the participants and 2 boxes placed on the floor. Participants could see their virtual avatar from a first-person perspective and also reflected in the mirror. Then, next step was introducing the full body ownership illusion of the virtual avatar, the sense of the embodiment, that is feeling the virtual avatar as the participant's own body by using a visual motor and visotactile stimulation. The next step was attentional bias modification training. The goal was to balance attentions between weight-related and non-weight-related body areas through the visual fixation on specific body areas, through geometric figures that appear on specific body areas. During the training, in 45% of the trial, the figures appear on weight-related body areas, in another 45% on non-weight-related body areas, and the remaining 10% on 2 boxes placed on the floor, the neutral stimuli. 2 variables were assessed before and after the training: body dissatisfaction and also body-related attentional bias. Body-related attentional bias were recorded inside the virtual environment by determining the participant visual fixation on the body, on their body. Visual fixation is an involuntary act of maintaining the attention on specific location at least for 100, 200 milliseconds. The 2 areas of interest of the body were the weight-related area of interest in yellow and non-weight area of interest in blue. Visual fixation was estimated by 2 variables: the complete fixation time and the fixation number on the 2 groups of area of interest. To assist the body-related attentional bias, participants were instructed to gaze at their body reflected in the mirror for 30 seconds, while the spontaneous eye movement were recorded. A pair sample t-test was used to verify if there was a significant reduction in complete fixation time, number fixation, so the attentional bias, and also in the body satisfaction levels. Regarding complete fixation time, patients reported an attentional bias toward weight-related body parts, but after the training, this time spent on weight-related body parts reduced until to arrive at balanced attention among all body parts. Regarding fixation number, patients reported a balanced number of fixation between weight and non-weight body areas that was maintained even after the training with no statistically significant change. And finally, also for body dissatisfaction levels, there was a reduction in body dissatisfaction after the training. So the innovations of our study are several. First, the goal of our tools was to balance attention by directing it to both positive or neutral and negative stimuli, instead to divert attention away from disorder-relevant stimuli as usually ABMT do. Also, we used measures of gaze behavior with really good psychometric properties. And finally, this is the first study that used an ABMT based on a virtual representation of the patient's real body in a highly ecological situation. So based on these preliminary findings, future studies should determine if this intervention tool could be used as standalone treatment or combined with traditional treatment as mirror exposure therapy. And also should determine if this could be used as preventive function in women with high body dissatisfaction level at risk of developing eating disorder. So, in conclusion, this virtual reality and eye tracking based ABMT has reduced attentional bias by reaching balanced attention among all body parts and also reduced body dissatisfaction levels. So it has really important clinical implication and also has the potential to become a new effective clinical intervention for the treatment of eating disorder. Thank you very much for your attention.
Thank you for adjusting perfectly to the time. So, do we have any questions in the room? I have a question about so you say this is a single session.
Yes.
So, but how long what is the procedure for this embodiment that you describe? Is it how long it takes for the subject to really
Well, the full body ownership illusion procedure lasts like 3 minutes. Yeah. It's
So
not long. Yeah.
It's super fast.
Yeah.
So before that, you have to build a representation of his or her body in a virtual reality environment, and this is this something that it's challenging from the computational point of view? I mean, how do you have standard types?
Create the avatar. Create the avatar.
Yeah.
No, it's not so difficult really. We have like system. We have like automatic system that with a photo of the participant will help us to create an avatar that have the same shape of the patient.
Okay, so it's all really fast.
Yeah.
Very good.
Yeah.
There's a question there, I think. Can we have a micro, please?
Thank you for the presentation. Did you compare the likability of the participants of their own pictures, I mean regular picture, 2D, to their avatars? Did they like better their body as reflected in their avatar or than their pictures?
Well, we are speaking about anorexia nervosa patient. This kind of patient have distortion, body distortion. So the most of time, patient will say that this is not their body because it's too big. I mean, the body have the same dimension of the patient, the virtual avatar, but they will say that it's not her body because it's big, it's bigger, because they have distortion.
I see. And compared to pictures or to other criterion like seeing themselves in reality in the mirror?
No, it's the same.
It's the same.
Yeah.
Okay.
In first person and third person perspective.
Okay, so thank you very much. So next speaker is Franck-Alexandre Meschberger-Annweiler. I'm sorry I didn't mention it well. By the virtual reality group too, so from the institute, and the presentation is called Attentional Bias Modification through Virtual Reality-Based Body Exposure to Enhance Efficacy of the Treatment of Anorexia nervosa. It is not.
Can you hear me? Yes? Yeah. It sounds the same, the flash talk before. In fact, I will present you the full project while Mary just introduce you one study in a full project that is larger than that. So I will go on just introducing the full project and many results of interest we could achieve so far. So virtual reality, in fact, stands for a very good opportunity for researchers and therapists to work on the treatment of eating disorder, generally speaking. I know it's difficult talking about eating disorder just after the lunch, so thank you for your attention. In fact, it enables us to create a highly realistic environment, immersive environment associated with the weight and body concern of the patients. On the other side, as Mary described before, we can create 3D avatars, really realistic, based or fitting the real silhouettes of the patients, including the clothing, the skin tone, and other specific characteristics of the individuals. The same way, we can simulate the movement in real time of the patient. This is called, in fact, the full body motion tracking. Well, this project is a part of what we call the embodied medicine. The embodied medicine is a transdisciplinary research field aiming to use advanced technology to alter the experience of being in a body. In fact, we use the full body illusion paradigm here, and in fact, the embodied medicine has shown very promising results so far through, in many disciplines, through many studies so far. So as Mary mentioned, we combine the virtual technology with eye tracking technology. Well, in that case, the eye tracking has been shown to provide directly, continuously, and objective measurement of fixation patterns. And in the case of this project, we use it basically to enable the attentional bias modification task, as we need to know where the patient is looking in each moment, and also to assess the attentional bias. So this is very important part for our study. So just to introduce you a little bit the virtual reality lab where we are working in fact, we have a very large experience in virtual reality application for mental health application. One of the first experiments we have designed are about craving to smoke and alcohol craving. We created immersing a significant environment for these patients in order to reduce the anxiety facing the significant stimuli for them. So you can see some example here about different kind of environments and the way we assess the reduction of the anxiety, so we can follow the progress of each patient. But the real specialization of the lab recently is more oriented to the eating disorders. In that case, we also designed some significant environment for these patients related to food cue exposure or body exposure. And also we designed a special image assessment, body image assessment software. So regarding the current project, as Mary mentioned, the VR technology allows us to create realistic mirror exposure environment, ecologically valid, also a realistic avatar fitting the participant silhouette, enhance the full body ownership illusion through visuomotor and visuotactile stimulation, and modify the avatar body mass index progressively. So we can manipulate the reflection in the mirror, and also to implement for the first time an attentional bias modification task through the virtual reality technology. So Mary explained the attentional bias modification task, so I will not extend me too much on that. So you have seen it before. It's the projection of different geometrical figures on the reflection. So the participant has to stare constantly on these figures during 4 seconds, and then we change the figure. And the projection is balanced between weight and non-weight related body parts. So also the AT technology, as I mentioned before, enable us to assess the attentional bias, both taking into account the complete fixation time and the number of fixation, 2 different constructs of the AB. And we processed all the data through Ogama software. So regarding the project, the main objective of this project is to reduce the body-related attentional bias, but also to reduce the body image disturbances, body dissatisfaction, fear of gaining weight, recognized, considered as the main risk and maintenance factor of anorexia nervosa. So what has been already achieved through pilot studies? Well, we have demonstrated with a study with non-clinical participants that women paid more attention to the weight-related body parts than men, which in turn paid more attention to non-weight-related body parts, and specifically muscular-related body parts like shoulder and arm. For the woman, it's more the stomach and the hip. So another study enabled us to analyze that the patients with AN showed higher level of fear of gaining weight, body anxiety, and body-related attentional bias. Another study enabled us to show that the attentional bias is, in fact, mediates the relationship between the body mass index and the body dissatisfaction. This is a clue part for us because that validates the fact that the attentional bias is a key factor in the maintenance mechanism of anorexia nervosa. Another study showed that after a body exposure therapy where we increase the body mass index progressively session after session, where we could get a significantly lower values of fear of gaining weight and body image disturbances. And finally, we could test also that after 150 trials of the ABMT, the attentional bias modification task, we already have effectiveness in the reduction of the AB. So this is important because that enables us to optimize the efficacy of the intervention and also the duration of the intervention. So we'll pass this. So regarding the clinical study, well, we start now the clinical study, or after maybe 2 months ago, we started this clinical study in collaboration with the Hospital Sant Joan de Déu in Barcelona. With 3 groups. It's a randomized study. A first control group with the treatment as usual, which is CBT usually. Second group with, in addition, the VR-based body exposure therapy. And finally, the experimental group with, in addition to all of that, the attentional body modification task. So the results so far are not known, but we already have the preliminary result that we have from the presentation of Marie before as a pilot study, where we could get with this, with only 1 session, significant reduction of AB and also on body dissatisfaction levels. So this is promising results, so we expect that the clinical study will confirm that. So as a conclusion, the virtual reality and eye tracking technology might improve the research and clinical practice in anorexia nervosa by providing new tools to help patients confront their core fears, in that case, body and weight-related fears, and improve their emotional, cognitive, and behavioral responses to their body image. So thank you for your attention.
Thank you very much. We have time for 1 question.
Thank you for your talk. I was wondering, I know how you try to be as reliable as you can with the avatars, but I want to know your opinion about how important or which is the weight that we are lacking of not using the face because it's where the device is located.
In fact, it's rather difficult to use the face because in the moment that we are doing the intervention, the patient is wearing actually the head-mounted display. So if the reflection in the mirror is a complete face where she can see, usually that's women, if they can see reflection with the full head, would be a little bit strange. That's why, well, usually the avatar is wearing kind of glass that simulate the real condition, because it's very important for the full body illusion that what you feel also, and you feel the head-mounted display, in fact, on your head. So if you see a head that is not wearing anything, that is completely free, it doesn't fit between the tactile sensation and what you see in the mirror. So it can be an obstacle, a problem in the full body illusion creation. So that's why we choose that. It's not perfect, we know it, but this is that was a compromise that we adopted in order to maintain as much as possible the FBI in the intervention.
Thank you. Thank you very much, Frank.
Thank you.
So the last speaker is José Valenzuela from the Brainlab group, also here at the Institute, and the presentation is called A Convolutional Neural Network Approach for Auditory Stimuli Classification from the Frequency Following Response.
So hello, good afternoon, and thank you for these minutes that I will have to do what is going to be the first public talk that I can do. About our technological solution that we have developed at the Brainlab, and that has recently, I think I can use this, has recently received a couple of grants related to innovative projects to do what is called a proof of concept that moves a little bit our research to the society or to the market, if you want to say it. And you can ask then a solution to what, okay? As you have heard yesterday in my colleagues' talk from Miriam and also my good friend Natalia, we have found that infants that are born at term, but they are small for their weight, are at a high risk of neurodevelopmental delay. Around 30–40% of these newborns could have this problem. Okay, the thing that we have found and that we know is that there is no any detection procedure or technique. So let's say that the family finds that problem when the problem appears. Okay, so they start to see that something is going wrong with the language of the child. Then they check it and they see the problem. This is when they have 1–2 years, and we can say that this is late to do something with that, okay? But we know, thanks to the work of my colleagues, I'm very proud of my colleagues, that there is a potential biomarker to this problem, to find this problem, this potential problem, that is the frequency following response, or FFR. That is related to these functional deficits in the encoding of complex sounds, okay? So having this in mind, okay, and knowing that there is a correlation between this FFR at birth and also some neuropsychological tests and also genetic tests at different ages, so at 6 months, 12 months, 24 months, we know that in some way we can try to predict this neurodevelopmental delay, just making this measure at birth, okay? So we were thinking about how to find a solution to that problem, and we started to think, okay, we have a growing database, we have more than 300, I think, newborns nowadays, and not just with data at birth, but also at 6 months, 12 months, 24 months. So we thought, okay, we need something that could help us to find some patterns between this data, also to predict from the data at 0 months, or at first week of at birth, and to see if this solution could learn with more and more data that we can be using to feed this system. So we thought that a good choice could be to use a machine learning system, okay? We didn't know nothing about machine learning, so the pandemics, let's say, that helped us to do a lot of online free courses in Coursera and resources like that. I suppose you are familiarized with this same solution in some of your cases. But the goal, the idea, was to develop an AI system, an artificial intelligence system, that could use data from all the different stages that I've told you about the age of the newborns, to just using this FFR at birth could give us a qualitative indicator of the baby's risk of this neurodevelopmental derail, okay? So with this indicator, we could say, okay, we have enough time, like 1 or 2 years more than what is done nowadays, to do any kind of, let's say, solution or treatment with the newborns to try to reduce, at least, this potential problem that they will have in the future. Okay, so checking learning a bit about machine learning, we saw that the system, the machine learning, help us to do these predictions, and their performances improve with more and more data we use, and concretely, the deep learning systems tend to use vast sets of data. We weren't sure if our set of data was vast, so we thought that we could do some tests to see if deep learning was the good choice for our problem. Okay, so for the first approach that we did to the use of this deep learning system, we used data from 2 different studies, from my colleague Tere, that is there, and also Sonia, that she's in the US. With just a difference that from Tere, we had 52 newborns that used the DA stimuli, okay, and 34 newborns that use the OA stimuli. So our first idea was to do a classification task, let's say a simple classification task with our system, with our algorithm, to see if they could use these inputs. Okay, this is the FFR response. It's the average of 50 responses to the same stimuli, or that. And it's, let's say, a single sample to feed the system, okay, to train the AI system. So thinking in the architecture that we could use, we read a lot of the bibliography, and also the different reviews that were in relation to use of machine learning systems and EEG data, and we saw that in relation to deep learning, the most common structure was the convolutional neural network that is normally and was born to be used with images, this one here, and what it basically does is to take the image, to find some features, and from these features find the different weights that they have, and do a final classification depending on your choice, okay? In our case, was to classify between OA or DA. So this was, as I said, the input data, but it wasn't not a 2D image, the classical 2D image, the picture, but also, let's say, a one-dimensional image that was a vector, because we saw in the bibliography that was also used, and is better for the performance of the system. It works faster. So these were the results. We make some tests with unknown data for the system, and we arrived to accuracies raising 98%. So at first we thought we were having any error. Okay, thank you. But no, because we checked that reducing the number of newborns that used to train the system, we saw that the accuracy was getting low. But taking more or less 10 from each of the stimuli, the accuracy was close to 95%, so it was fine. But you can say, okay, this is not related to the quality of hearing. So we tried to use the same structure, but changing to just using the DA stimuli, the newborns with the DA stimuli, but dividing in good and bad, let's say, processing that was calculated with a parameter that I cannot share because it's confidential, sorry. But we saw that the accuracies were lower, but we are working in these months to try to get and try to rise to, I don't know, to higher levels. So this is more or less the first study that I am doing with the proof of concept. What we want to do is to continue to arrive to a final, let's say, solution that could be also predicting system that could be used in real cases in clinics. So I hope in a couple of years I can be here again telling you that we are using in hospitals to enhance the quality of life of these newborns and for sure their families. So thank you to all of you and for sure to all my team, because without their work, nothing of this could be possible. So thank you.
Thank you, Jose. So we have time for one question. Isn't it? There's one question there by Jose.
We are friends in Twitter.
Okay, I will ask you later if not. Well, thank you. It was a nice talk. I was just wondering if you could use the results of your algorithms to improve the stimuli.
What? Sorry?
So to use the results, so let's say some kind of feature classification, to change the stimuli that you give to the system and perhaps to improve the overall
you mean finding a different stimuli that could have better accuracy? So
if you identify which features are giving the best accuracy, perhaps you can go back and change a little bit the stimuli for I don't know, it's like for like longer.
What you are saying, I think is very interesting. The thing, my limitation, at least in my research, is that we are using data that is already existing. So the data is not, we are not getting new data in relation to my research, but by the research that has been done from, I don't know, 2015 or 14. So we have found that, in this case, the OR and the DA are giving us the important information for other research that is not related to that. So I have to more or less to get used to use this. But no, I think it's very interesting what you are saying.
I mean, perhaps you could use it just to provide some kind of recommendations for further studies or something like this.
I totally agree with you. Thank you.
Okay, thank you.
Okay, so thank you very much to all of you for attending the session, and I will leave it to Professor Jordi Alberg, the director of the Institute of Neuroscience, for the closure plenary session. Thank you.